Hello and welcome to WorldCanvass from International Programs at the University of Iowa. This is part 2 of a 4-part series on child protection, a global responsibility, the theme of the 2014 University of Iowa Provost Global Forum. Our subject is child abuse and neglect, which is unfortunately a global reality and one that has long-lasting impacts on children, the adults they become, and the societies they live in. While we'll be discussing the prevalence of child abuse and neglect, we also want to talk about interventions and treatments that may be appropriate both before and after the abuse occurs. And in this segment, we want to focus on Iowa by asking who's looking out for Iowa's kids. And my guests are just next to me, Dr. Debra Waldron, Vice Chair for Child Health Policy and Clinical Professor in the Stead Family Department of Pediatrics at the University of Iowa Hospitals and Clinics. Welcome, Dr. Waldron.
Thank you very much. It's happy to be here.
Thank you. And next to her is Dr. Jack Widness, Professor of Pediatrics and the Director of the Child Health Research Corps of Iowa's Institute for Clinical and Translational Science at the University of Iowa College of Medicine. Welcome, Dr. Widness.
Thank you. It's a pleasure.
Thank you. And next to him, very happy to have Marcus Johnson Miller with us, who's the interim First 5 State Coordinator at the Iowa Department of Public Health. And you'll explain to us what the First 5 State Coordinator is, I know, as we go on. So welcome.
Glad to be here. Thank you.
Yeah, thank you. So I'd like to begin with you, Dr. Waldron, if you don't mind. You're a pediatrician, and obviously you work within sort of the guidelines and also help to develop the agenda for the American Academy of Pediatrics. How do adverse childhood experiences and toxic stress, how are they approached by pediatricians, do you think, around our country?
Sure, that's a great question. Actually, our national organization, the American Academy of Pediatrics, has viewed child health and the adverse effects of different things on child health as one of its priorities for many, many years. Over the past couple of years, they've actually been looking at things such as poverty, as well as early childhood brain development, and now most recently adverse childhood experiences and toxic stress. Our Academy actually came out with policy statements about adverse childhood experiences and toxic stress and what pediatricians should be doing within their office, as well as what they should be doing in the community to help identify, raise awareness, as well as start to intervene even before these events occur. So there have been advocacy efforts, there have been policy statements created, educational programs, as well as research. And as we heard in our speaker before, it's very important to conduct research, and I think Dr. Widness will talk a little bit about that on the things that the University of Iowa is doing.
Yeah. Well, thank you. We'll throw it to you, Dr. Widness, so you can tell us a little bit about clinical and translational science and what that means to the study of this area.
Okay. In terms of some of the things that we've talked about earlier with adverse childhood events, it's something that we're still learning about. And we know something about the epidemiology of this, and we know that this is an important area. But I think one of the things that we would like to know even more about are what are effective therapies. And so this is one of the things that at the University of Iowa, the Institute for Clinical and Translational Science is particularly interested in. This institute is funded through the National Institute of Health. There are 62 other facilities throughout the United States. Our focus is in Iowa, but we're also working nationally to address some of these issues. So what our group does is to work with the community, as well as work with our partners throughout the state, Iowa State, University of Northern Iowa, and the University of Iowa, to try to get people to work together, because this is a multidimensional problem. We all need to work together to begin to solve this. And by working together, I would also emphasize that we need to hear from families and from children to know what the needs are and how we can best serve them as a group. And I would say that we're in our infancy, as it were, with this compared to what we know epidemiologically in terms of what works. So the ICTS is trying to be a facilitator to provide infrastructure to groups such as the Department of Public Health, the Academy of Pediatrics, all of whom we're beginning to work with and try to realize some of the things that we think will really affect Iowans and children.
And actually, I was going to say, one of the wonderful things is that actually the Iowa Department of Public Health is working closely with the American Academy of Pediatrics on their First Five program and multiple other programs devoted to child health. So I think hearing a little bit about First Five might help set the tone of what's going on in Iowa.
Yeah, please.
Sure. The First Five Healthy Mental Development Initiative is a partnership between primary care providers and public health. And basically what they're doing is site coordinators in public health are working with those primary care providers to do developmental screening and surveillance using standardized tools so that they can identify those areas early. What we know is nationally, 70% of primary care providers use only observation to identify developmental delays, and observation alone only identifies 30% of developmental delays. So if they're not using those standardized tools, we feel that they're missing some of those diagnoses or risk factors that may happen. Along with parents, primary care providers really do play a critical role in identifying developmental delays and risk factors. In Iowa, 90% of children 0 to 5 participate in well child exams or primary care visits. So we know that parents are going to the doctor with their children. There's no other system that more universally sees children than going to the primary care doctor. The First Five model really is in 4 steps. The first step is the primary care provider does surveillance. The surveillance looks at development of the child. It also looks at family risk factors. It looks at caregiver depression, maternal depression, autism, and things like that. So it goes beyond the just the health of the child. If a condition or risk factor is found, they make a referral to First Five, which is in the public health office, to do the care coordination for them. So the nurses don't have to spend the time finding resources. The doctors aren't taking time to make referrals out. They can make a one-stop referral for any type of condition to public health. Then the care coordinator follows up with the family, make sure they get connected to resources that they would need to help with those developmental delays or any risk factors. And then the last step into the system is the care coordinator then works with the primary care provider to say, here's what we did with the family. So they close that loop. So the physician knows, once I made that referral, what happened when I made that referral. So it's a really comprehensive system. And what we found through First Five is that for every one referral that a physician makes, 3 other referrals through public health are made. So, for example, if a physician made a referral for a speech or language delay, through the care coordination, the care coordinator finds that there might be a transportation issue, childcare issues, maybe they're living in transitional housing. So those are all things that the care coordinator can help with, along with that speech delay that the physician found. We also know that children of mothers that have maternal depression, if it's an infant, we see that they're withdrawn or avoid interaction with the mother. Toddlers are sometimes aggravated or irrational. And what we know is if they didn't do the surveillance question about maternal depression, they would treat the kids, maybe give them medicine because they think they have ADD or some sort of condition like that, but they wouldn't treat the mother's depression. So that's why it's more comprehensive. Sure. So really the First Five model is all about prevention and early intervention to avoid longer term effects.
Sure. And so here you're asking the parent to answer the question. Obviously the child is too small.
Right.
So the parent then has an opportunity to say, yeah, I've been struggling with depression for a long time and, but I'm taking good care of my child, but I have depression. And then you try to help find resources that might assist this parent.
Yeah.
Yeah.
And actually one of the good things that will help First Five actually move along is with the passage of the Affordable Care Act. Mm-hmm. We know that as part of the essential health benefits, Bright Futures, which recommends surveillance as well as screening at a prescribed time during a child's life, will help make that be the standard of care. So again, it's a nice interface between what Iowa's been doing for many years in terms of First Five to now know that our national health reform is helping us do our job even better.
Sure.
And then the second thing that Marcus talked about was actually being able to identify whether or not First Five is making a difference. So again, there's that partnership between the University of Iowa and our division working along with Iowa Department of Public Health and the Child Family Policy Center in Des Moines to identify those things that will let us know that the measures are there, that we actually are making a difference. I mean, anecdotally, we know we're making a difference. Parents love the model. Kids are doing better, but we want to be able to prove to other individuals that we really are making a difference. So again, that's the realm that ICTS can play, along with our Division Department of Pediatrics, Iowa Department of Public Health, making sure we're moving the agenda forward for kids.
Sure. And how long has this collaboration been going? How long has the department, for example, been involved in this?
Sure, the First Five program has been around since 2007.
Oh, wow, good. So there's some history there. I remember reading when doing some research that an easy first assumption might be that an adverse childhood experience might happen in one socioeconomic class more frequently than another. Is that true? Or are these issues and problems that really, come through any portion of society?
Sure. We know that ACEs know boundaries. They do occur in all walks of life. The unfortunate thing is we do know that if a child is living in poverty, and about 20 to 25% of children in Iowa are living in poverty, below 200% of the federal poverty level, we know that if you're experiencing ACEs and you overlay poverty on top of that, there's a chance that your outcomes may be worse. We do know that ACEs are not destiny, and as our previous speakers talked about, we do know that resiliency, and probably one of the number one things in resiliency is having a caring individual in your life. So we do know that changes can be made. So if you do have one ACE or two ACEs, we do know that, again, that is not, it may affect your trajectory, but we can intervene early. That's why First Five is beautiful, because if we can identify at 3 months, 6 months, 12 months of age that an adverse event has happened, or has happened in the parent's life as well, because we do know that ACEs, unfortunately, can be transgenerational, move from one generation to the other. There's actually a science behind that. It's called epigenetics. So we talked about toxic stress, we talked about cortisol, and then I think Dr. Nicoletis was going down that track of saying that it actually impacts, there is the biological and the chemical things that happen within the body. It actually changes the genome by causing certain changes within the DNA structure, and that actually gets passed on to your child. So again, there's a lot to be done in making sure our kids are healthy even before they are born.
Wow. And in your research, Dr. Widness, I'm interested in this whole business of whether people are resistant to opening up some of the darker parts of their lives, maybe. Have you found that that's true? Or people are really looking for they recognize that there has been a problem somewhere along the way, or that they're suffering even if they haven't had anybody to talk to. Do you find that there is this willingness to share that with someone who might be able to offer help?
Well, I think there is within the right environment and presented the right way, such as Dr. R. Rao was talking about earlier, beginning with topics that cause less stress among individuals, such as parental separation, and then moving down into other areas as well. I would tell you, though, that I'm not an expert necessarily in ACEs, but my role is really as an individual to try to bring groups together to study these things. And a couple of the points that I would like to make is, ACEs is a huge topic, and I hope we all understand that many different facets to injury or sexual abuse and other aspects of this that pervade our lives. And so all of these things cannot be dealt with at once. And so one of the things that we're trying to look for within the ICTS is to look for good fits. That is, do we have the researchers here at Iowa State or elsewhere that can answer these questions to develop the evidence that we need to make these even more effective than the therapies that we now have? And it may be focusing down on a few of the areas and not trying to do all of them all at once.
Right.
But we have to find these good fits, and it's like a building, one brick at a time, and you have to have the right people present with the right interest to really move this along from a research standpoint, as they say, because it's so large and so all-encompassing.
Yeah.
And what we found in First Five is that family stress is the number one reason for referral from primary care providers, whether it's pediatrician or family practice doctor. So even though they're doing developmental screening and looking at how children are developing, and it's really the family stress is why they're getting referred into the First Five program. So the top types of referrals are housing, food, childcare, transportation, those types of things. And then secondly are the health needs of the child, so like hearing, immunization, lead screening, those types of things. But so that really does go to show it's family stress that people are getting referred in first 5 over some of those health and development things.
Can you give us an example, Dr. Waldron, just before we break this segment up, about an example of either an individual or sort of a common sort of issue that might trigger your concern with someone you've seen in your clinic?
I think actually one of the things that I think the previous, I think it was Dr. Runyon talked about, it may be that when you're seeing an infant, they may not be showing that bonding with the parent. When the parent comes into the exam room, they put the child on the table and don't necessarily coo or cuddle with the child while they're waiting for the physician to come in. With the toddler, it may be that toddler that's running around the room doesn't seem to be interacting with the physician or the nurse as well as they could be. In an older individual, it may be a teenager that for some reason is turning to some sort of alternative substances to soothe themselves. So there are a lot of different red flags that we see. It's great though that we're working with First 5 to help embed those standardized tools that would allow decreased variability between practice and practice, so that if you go to practice A or practice B, you're still receiving the same standard of care.
Could I ask one of you to respond to a question about what you see coming next? You've already mentioned the Affordable Care Act that may help more people see doctors more regularly and so on. But what do you think happens next year? What are you hoping for can happen in the next 3 to 5 years?
Well, obviously increased awareness. We want everyone to be aware of the fact that our children are experiencing adverse events that really are impacting their future health. We know that if a child has a number of adverse effects, it affects their neurocognitive development, which then goes on to, may lead them to adopt unhealthy behaviors. If you have unhealthy behaviors, you may have risk factors that then cause you to develop a chronic condition and then early death. And we do know that individuals that experience ACEs die much earlier. In fact, adults with mental illness die 25 years earlier than individuals that don't have mental illness, and adverse childhood events can obviously cause someone to have emotional and behavioral stress. So we hope that we will be able to identify these things early, intervene, and make a difference in the future.
Yeah.
I think awareness is key as well. Awareness, I would say, and that's one of the things that's being accomplished by what we're doing here this evening and the last 3 days of the Provost International Symposium on adverse events in childhood. And I think we need to have the people of Iowa become aware of that, not just the caregivers, but families as well. And what we're also hoping is that by creating awareness, we will also have mechanisms for knowing what the public feels is important problems, which are the research groups, and what are the resources we have, whether it's with the health department, the Academy of Pediatrics, and other groups, so that we could work with them to, as they say, get the word out, but in addition, begin to then hone in on some of the problems. And one of our aspirations is that we hope that we'll be working increasingly with the public on this, because this is a public-private enterprise. For us to advance, we have to know what families are thinking and what it's like for children. If we don't have that information, we're not going to be nearly as successful. So we need to go to where the boots are on the ground, and this is where Dr. Waldron's programs have been very effective, as well as the Department of Public Health. And I think by working together on this, but working together on problems that are solvable, that are feasible, we will develop, I think, the evidence that maybe beyond next 5 years, where we can bring the cost of this down even more and make this increasingly effective and have people leading healthier, happier, more productive lives.
Yeah.
That's our goals for the next several years.
Yes. And is there anything you'd like to add?
Yeah, I was going to say, selfishly, I want statewide implementation of First 5. Currently, we're in 49 of the 99 counties in Iowa, so it's not a statewide program. So in order for us to meet the needs of all children and screen early and get them the assistance that they need, I would like statewide implementation of First 5.
Sure. And if someone out there is watching this broadcast on television, or they're listening to this broadcast, and they feel that they may have something they want to discuss with any of you or a healthcare professional, where should they go? To whom should they speak first? Should they talk to their family doctor? Should they try to get a hold of one of you through the hospital or Department of Public Health?
I think all of those avenues are great.
Yeah.
Obviously, we always would like individuals to talk with their healthcare professional because they are experts in healthcare. But obviously, if they have questions about the programs, ICTS, or our division, they can contact us, the University of Iowa or Iowa Department of Public Health.
You know, I haven't asked about the public schools, but is there a mechanism by which a school teacher, say in an elementary grade, if they feel that there may be a problem and maybe they've even talked to their own school administrator or principal, you know, I'm worried about this particular child. I don't know how that works within the schools. Does someone contact the Department of Public Health or a local social work agency?
I think it would depend on the school district. There's always the privacy laws of HIPAA and FERPA and those
Sure.
types of things. But definitely, if they found an issue with a child, they could contact the public health agency, the First Five agency, and we could help link students to services. Also through the area education agencies or the AEAs, they could work through their Part C early access program or the Part B
Sure.
special education.
And we always recommend that the school advise the parents to, again, contact their healthcare provider because we want it to be a comprehensive team that's wrapping themselves around the child and the family.
Sure.
Yeah, I think it's a really excellent question, and you're honing in on an area that's very important. And one of the things that I would say is a real strength here at the University of Iowa is the College of Nursing, also in the College of Liberal Arts. There are several groups that are working with school nurses. And over the last 6 or 7 years, with help from the ICTS, they've been having meetings with leadership across the state in terms of school nurses to try to look at some of these issues and devise ways to, as they say, make the state dollars and federal dollars go even further and provide even more effective ways to deal with these issues.
Well, this has been very, very helpful. Thank you all for being here this afternoon to share this information with us. And unfortunately, we're at the end of the time we have for this segment. But this has been the second part of a 4-part series on child protection, global responsibility. And just next to me here is Dr. Debra Waldron. We've also been joined by Dr. Jack Widness in the middle, thank you, and also Marcus Johnson Miller there at the far end. So appreciate it very much. And I hope all of you can join us for part 3 of this series. And WorldCanvass programming is available on YouTube, iTunes, UITV, and the International Program's website, which is international.uiowa.edu. I'm Joan Kjaer. Thank you for being with us, and we'll see you next time.